Well, I'm pretty fortunate to be included in a model that's been in existence for an extended period of time and has actually been really successful. When I was here as a medical student, the model was that the family doctors provided most of the delivery services, handling the low-risk obstetrical cases, with support by the obstetricians. And it was a point of pride for the family physicians and the obstetricians who had been here of that generation that model continue. And it became part of the physician group's ethos that was an important thing to continue. So they really planned across generations to keep this thing going, you know, made sure that they would get new obstetricians, get new family doctors who were interested in being part of the program. So I've kind of benefited from the way the program was before, and I've also been very fortunate to join the program with the group that we've got here now. I mean, we've got Steve, we've got Jen Mercer, we've got Theo Cabicios, who are all a group of MUN-trained obstetricians who we've known from our medical school days. And with that, a really great group of primary care providers. I mean, you've got older gentlemen who've got a wealth of practice, like, you know, Dr. King Jim. You've got doctors like Helen Bruce, who've been at this forever. And then you've got an intermediate group who are very exceptional and committed to what they're doing. So I've actually been very privileged to join a group that was very functional and committed to quite a bit of excellence. Well, again, more in a supporting role. I mean, this was the brainchild of Steve Parsons. The idea was that, you know, we are a regional referral center, and there's a fairly significant turnover of some of the physicians in the smaller communities who refer in. And we thought that, you know, we shouldn't just limit our practice of obstetrics to what it is that we do within our facility. Things that happen outside of our facility impact on the care that we can provide, and we kind of have a bit of a social obligation to see what we can do to help out fellas in the periphery. And that was kind of Steve's mindset. So we thought, now, what's the best way that we can go ahead and deliver a high-quality CME CPD in the periphery? I mean, there's a number of good courses, but they're fairly time-intensive, and that just doesn't fit with the very busy practices that most of our colleagues in the rural and remote sites actually have. So the thought was, okay, let's go ahead and get, let's brainstorm this a little bit. And we thought, hold on, it's 2014. You know, if you can go on YouTube and figure out how to put the blinds up in your house, maybe we can leverage that familiarity to help get some high-quality medical education out there. Get as much of the pre-reading, pre-course work done as possible, so that the time that we actually spend in these sites is high yield, hands-on, building teams, building skills, getting processes and policies to allow for dealing with obstetrical emergencies, and packaging for transport to our original referral center. So kind of the idea was that we'd use some internet videos, some didactic presentations, some reading materials, and then skills-based stuff. The bit that I can kind of bring to this is I'm reading towards a master's degree in clinical science at the University of Western Ontario. Teaching and learning and research methodologies are part of that. And with my involvement with the Faculty of Family Medicine, we know a number of individuals who can help us with the evaluation to see what metrics we should be using to determine the extent to which we're delivering what it is that we purport to want to be able to deliver. So kind of more in a supporting role with some of the nerdy background research stuff.